he was wishing that he could be present, but he is not. But he has sent his best wishes, and he hopes that you all will enjoy today's session. The other thing is that Dr. Suple wanted me to convey to you all is that I don't know whether you are aware or not. International Chapter of IOTA, it sponsors researchers and provides them funding, some kind of encouragement to undertake research. And this year we selected two such applications, and they got that funding they'll be getting in due course of time. We have already got 5 sponsors for the coming year. So please watch out the space and keep looking at our website. You will get some details there. If you want to get registered, if you're a student, if you want to get registered on the International Chapter of AIOTA website, you can do that as well. And of course, most of board members whom you are seeing tonight, uh, we are quite approachable, so please feel free to approach us. Without wasting much time, I'll hand it over to Dr. Shruti to introduce Dr. Sabarish, who is today's speaker. Thank you.
Thank you, Dr. Harsh. So I would like to start this webinar. So I'm just going to introduce the speaker to you. Dr. Sabarish Radhakrishnan is an occupational therapist who has completed his bachelor's in occupational therapy from Santosh College of Occupational Therapy, that is in Tamil Nadu, Dr. MGR Medical University, Chennai. He has over 18 years of experience working as an occupational therapist in various settings, ranging from industrial occupational therapy and pediatrics to secure mental health settings. He has been working in Australia for the last 14 years as a registered occupational therapist, practicing within the mental health, justice health, alcohol and drug services, Canberra Health Services Act, and forensic medicine health in Australia. He currently manages an adult mental health community mental health team and has a wealth of experience working in mental health crisis support and implementing community model of the care projects. He is a registered mental health officer in Australia and a senior clinician within the occupational therapy fraternity in Australia. He is registered with the Occupational Therapy branch of the Australian Health Practitioner Regulation Agency and a board member of the International Chapter of AIOTA. So I'm handing over to Dr. Sabarish. I hope all of you enjoy this webinar. Thank you.
Thanks, everyone. Thanks, Karthik. Thanks, Harsh. And thanks, Vijay sir and Shruti ma'am. Thanks for the introduction. And thanks to all the participants who have joined us in the webinar. Yeah, like Dr. Harsh was saying, we're all from different time zones. Without any further ado, let's look at starting the webinar process, and we will start the presentation. Okay, fine. Is my screen being shared now? Let me just. I'm just trying to share the screen. Just give me 1 second.
Sure.
There we go. Okay. Is the screen being shared now?
Yes.
Perfect. Thank you. Thanks to everyone to joining the webinar, and it's great to see such interest in this topic and engagement in learning activities. So let's look at the occupational therapy and mental health and the emerging trends from an Australian perspective. That's where I've been practicing as an OT, like the introduction was given. So let's look at it. The topic itself is it's a very broad topic. So within the given time frame, I've tried to concise the areas of interest as much as I could. So with the aim that we will do more engagements and webinars with the rest of the mental health topics based on the interest. So looking at the brief history of occupational therapy itself, the fun fact is we as a profession started in the mental health space. Occupational therapy itself started in the mental health space. And probes such as An Ideal Mind is a Devil's Workshop establishes the connections of engagement in activity and mental health. So Philippe Pinel, who is a French physician who pioneered in the humane treatment of the mentally ill, he's often attributed as the father of modern psychiatry. And where his role in occupational therapy is, he was instrumental in formulating a treatment modality called the moral treatment movement. So this moral treatment movement assisted in formulating treatment for the mentally ill based on purposeful activities, and more so engagement in purposeful activities. So in short, what Pinel did was identify that engaging people with mental illness in meaningful activities actually helped to assist in improving their day-to-day functions, what we call as ADLs. We as OTs call as ADLs. So his contributions to our field is immense, and this is followed nicely by looking at the origins of occupational therapy as a profession as we know it. And the contribution should go to Mr. William Rush Dunton Jr., who is often referred as the father of OT as we know it. So he is credited to formulating the principles of the therapy of the profession as such, where he identified and established the recovery aspects of engaging in meaningful occupational activities and linked it up with the process of healing. And his contributions is immense in how he formulated the theoretical frameworks as well. And in fact, he wrote a couple of books, and one of his papers is very interesting, where he talked about the principles of OT, wherein he wrote that all patients should have occupations which they enjoy, that sick minds, sick bodies, and sick souls may be healed through occupation. So he coined the term occupation is as necessary as food and drink. So this cements our role in the field and sphere of space of mental health. So most of you would have seen these old slides and old books where we talk about occupational therapists engaging in arts and crafts and dealing with sewing and stitching. These had a very important and crucial role in recovery in that stage. So the moral treatment movement that Pinel started, it carried over, and that flow-on effect had on people, especially the consequence of the World War One, which left a lot of veterans who are functionally dysfunctional now, and who had dysthymic reactions, who were suffering depression, and who didn't have any purpose in life. So there were a lot of suicides, and there were a lot of difficulties in actually managing these people in the inpatient setting. And discharge was a challenge, because they would go kill themselves because of boredom, and they couldn't do, and they were not the people whom they were, and they were shell shocked from the World War and the effects of it. So at that time, PTSD or post-traumatic stress disorder, it was still in the early infancy of how to treat these people. And the role of occupational therapy in actually assisting these people in finding an outlet through engaging in activities such as art and crafts, subsequently turning into these activities which were leisure based into some form of vocation based activities, gave a new meaning to these people. So this actually started a huge momentum where OT as a profession started getting recognized, and we started our role in dealing with mental health clients started through this historical perspective. So I take this opportunity to pay my respects and deep sense of gratitude to Shri Mrs. Kamalavi Nimkar for her contribution to establishing the occupational therapy as a profession in India as we know it for now. And she achieved this with help from numerous stalwarts, past and present of her profession, who guided and assisted in ensuring occupational therapy as a profession could grow in India to where it is now. So moving on, you would have often heard this term that occupational therapy is an holistic approach. So break it down. What is this holistic approach? So defining occupational therapy within the traditional medical model was like trying to fit a square peg in a circular hole. We never fitted in well uh, with the highly prescriptive medical model, because we always worked on the strengths based approach, and we were pioneers in actually adapting the strengths from and best qualities from other professions, but and developing the unique skills and characteristics to deliver a client-centered approach to our clients. So OT, occupational therapy, in that way, that's how we became holistic. So we, instead of just seeing the problem from a medical perspective, we saw the rest of the auxiliary supports available, the environment, the community, the family members, the strengths of the patient, and then worked on those strengths to actually assist the person in the recovery. So let's define occupation. So this is person-centered versus and or a client-centered approach. So taking the holistic approach of working with the client to enhance the ability to engage in occupations that they want to, or they are needed to, or they're expected to perform. So all these aspects of what do they want to do, or what are they needed to do to actually survive, or what are the expectations that they have to fulfill in the community. So how we did this is by modifying the occupation or the environment to facilitate the occupational engagements. So we were really good at problem solving with the client to see how best they can actually perform or engage in the meaningful occupation that they needed to. So defining occupation, yes, occupations are simply understood as the activities that people engage in they find a sense of meaning. And we as occupational therapists are trained in assessing the impact of mental illness on a person and how it affects their ability to function in their day-to-day occupations and roles. So it's fundamental to our practice and our theoretical frameworks, where we look at okay, if you're engaging in a profession, that's your profession, and then analyzing that to look at the engagement and enjoyment that they get from that, and to modify that aspect of engagement for them. And defining mental health. So, mental health is a state of well being in which every individual is able to realize his or her own potential while dealing with the normal stresses of life. So, while dealing with the normal stresses of life, when the person can still productively and fruitfully contribute to his or her community, that state of well being is called mental health. So this can be affected by various factors. They can be external or they can be internal factors. So that can affect the mental health of the individual. So, and it is evident that occupational therapy, with our key principles of achieving a balance between work, play, and leisure, have an immense contribution in ensuring that the balance is maintained, to ensure that that state of well-being is attainable and sustainable. So briefly looking at mental health or mental illness. So it is a condition that affects a person's thinking, feeling, behavior, or mood. So these conditions deeply impact day-to-day living, and may also affect the ability to relate to others. So the important aspect is the capacity to actually enjoy from things that they do. or even normal day-to-day activities that they participate in, which till when they are in a mental health state where they are able to enjoy the balance between the external and the internal factors and their self-realization of having gratification from what they do. And if there is an imbalance in that, it becomes really hard for them to actually to enjoy whatever they do or how they do. So there are different types of mental illness, and they occur with varying degrees of severity. So we'll briefly look at the broad classifications of them. So you would broadly classify them as psychotic disorders and neuroticism. So in psychotic disorders, it is more a serious mental illness that impacts a person's sense of what is real and what is not. So this could be because of factors such as hallucinations, where an altered sensory perception, where they see, hear, or sense things that doesn't exist. Or it could be in a form of delusions, where delusional disorders, where they have false beliefs that the person is conceived true or unreal or real. So some of the psychotic disorders that broadly fall under this category would be schizophrenia, the bipolar disorders, um, and then neuroticism. uh, this term derives from the historic concept of neurosis, which refers to a form of mental illness involving chronic distress. So there is this chronic state of uh, distress that the person is in. So anxiety disorders, they are a disorder in themselves. Post-traumatic stress disorders, and in these disorders, normally the person is able to retain a level of insight, and they don't lose the contact with reality, so they are able to still understand where, acknowledge who they are, where they are, and what they need to do. But they are in this constant state of distress where they are unable to do any functions because of the illness itself. And often this is more to a response to a stressor. So this slide, we broadly look at types of major types of mental illness, and about 1 in 5 Australians will experience. The data says that 1 in 5 Australians will experience some form of mental illness, um, and it's a health problem that significantly affects how a person feels, thinks, behaves, and interact with people. you know and it is diagnosed according to the standardized criteria. The term mental disorders is also referred to these health problems. So you may have heard that mental illness, mental disorders, these are interchanged depending on the diagnosis for that person. um, and mental illness as such causes a great deal of suffering to those experiencing them, as well as their family, friends, profession, the society in general. And furthermore, with the current COVID pandemic, WHO predicts that there'll be a lot of increase in conditions such as depression and anxiety related illness, where because people are unable to enjoy what they would normally do, due to the restrictions and lockdowns and whatnot, due to the changing health dynamics. People are expected to increase, have suffer a lot more, is what WHO is predicting. So how do we normally document these illnesses, or what's the diagnostic manuals? So in Australia and world over, I think it's the same. Normally it is through the DSM. The diagnostic manuals is the Diagnostic Statistic Manual, or the ICDM, the International Classification of Diseases. So what is widely accepted is the diagnostic manuals have their own limitations, and it is a very dynamic process. So you will have a lot of revisions in these diagnostic manuals. So the complexity of the patients and the presentations may not always fit neatly into these diagnostic category, but it gives us a broad understanding of what the problem is and what are the symptomatology that we are dealing with, and what is the recommended treatment. So it gives a framework from where we can start working. So now coming to our role as occupational therapists in mental health, uh, where do we fit in? So as we've discussed and briefly seen, um, our role and our origins are closely linked with mental health. Despite being well known in our role in physical health environment, there are not there are still some apprehensions about what do occupational therapists actually do. Um, so while working in mental health settings, we normally complete additional training to develop skills to work with people experiencing mental health issues. The focus is on how a person is functioning and how the symptoms are impacting on the quality of life. So, so it's about providing a meaningful treatment modality based on the functional deficits. So what we do provide is cognitive assessments, sensory strategies, group programs, socio-emotional skills. We look at the vocational skill training and assist in developing the activities of daily living. So that includes the ADL and the IADLs of the person. So furthermore, looking into the roles, so we assist in the behavior modification, the capacity building, social inclusion. We already talked about the ADLs of the persons. So it's more about how do we promote the quality of life for this person who has a diagnosis of mental illness. And then looking at the clinical process of this of our role. So we as occupational therapists work across a spectrum of mental illness, and we provide services to people with mild, moderate, or severe mental health conditions. So, but the core of our therapy is always strength based. We are behaviorally oriented and goal directed service to improve the mental health and well-being. So we always see the person as a whole. The holistic approach comes back, and we look at the varied roles that they play in their life. So there could be a student, there could be a son, there could be whatever they are in their life. We look at all aspects of their care and where they fit in the society, and and our interventions are designed to actually positively affect all spheres of their lives. And how we do this is more about developing an intervention plan. So it's normally a very individual, personalized intervention plan, um, and those guide us on the interventions that we are going to deliver. So sometimes these care plans that we develop with the person, we deliver them on an individual level. Sometimes it's just one-on-one, the therapist and the person sits in and we work with them. Sometimes it could be in a group settings. No, normally there are certain activities which we realize that maybe from an individual setting the person may find it a bit overwhelming, so we identify a group settings for them. So broadly looking at the problem areas when dealing with psychiatric patients. So this is taken, the data that I'm going to share is normally taken from an Australian perspective, where we look at about 1 in 5 Australians will experience some mental health issues, and predominantly the concern that we normally focus on is the cognitive deficits. So the cognitive deficits significantly contribute to poor functional outcome. So difficulties, this could relate from difficulties maintaining work, maintaining social connections. Uh, it affects their independence in living independently and acquiring skills from a large component of the disability. So this is often experienced by people with schizophrenia and other severe form of mental illness, but it is not restricted to just the severe form of mental illness. Even someone who has an affective disorder or going through a bout of depression would have significant difficulties in engaging in activities of their daily living. So the other challenge is many people living with mental health challenges also experience at times they can be homeless. There's the barrier of lack of services, poverty, isolation, very poor physical health, unemployment, and stigmatization. These are common throughout the world. So, as a therapist, we would deal with the clients who have mental health concerns, and on top of these, you have these social, psychosocial concerns as well. So, we as a therapist, when we are providing our services, we need to combine all these spheres of the trouble and then look at addressing all these aspects of it. So, and all these aspects significantly impair the person's capacity to engage in any meaningful recovery work. So that becomes the challenge that we face with. Uh, how do we design the intervention planning? It's often challenging in itself. Like I said, we have those barriers that we spoke about. Um, but apart from that, once you have a therapeutic relationship, how do we do it? The intervention planning is done by developing and obtaining measurable goals, and then by focusing on the environmental and occupational modification strategies, uh, which is more about how do we deliver um, an intervention for this person in the current setting. So when I say this, this is because we as occupational therapists in mental health don't just work in inpatient settings. We'll be working in community settings. We'd be working in acute settings. We'd be working in highly restrictive settings, such as in judicial settings, in forensic care settings, such as the corrective services and prison systems, or secure mental health facilities where it is hard to design a recovery program. What you would normally do in an rehabilitation ward, you would have a cooking group, but in a secure environment, the knives would be attached to an instrument to ensure that the safety aspects are handled, or you won't have access to things that you would normally have in a rehab settings. So it becomes really challenging as an occupational therapist to do the intervention planning based on the environment, based on the client's capacity, ensuring that there is a good interaction with the environment and the client's capacities and interests. So the client may be interested in doing X number of activities, but you would have only certain activities that you can actually deliver to the client. So it's about having this meaningful conversation with the client to ensure that the intervention planning is actually measurable and effective and interesting for the client. So this slide we broadly look at from an Australian perspective, where we have occupational therapists working in. So we work, well, like I said, we work in varied settings, um, and like you see, I mean, the forensic settings are very new. The community settings are a reasonable trend, and acute mental health settings are reasonably new too. So we've had a lot of occupational therapy input in rehabilitation settings with relation to mental health, but there's a lot of momentum in these new settings that's coming up. Okay, so and what assessments do we do in mental health? It's a very broad topic that could go on for us, but I'm trying to concise this aspect because in mental health, uh, our aim is about increasing the overall functional status specific to the individual diagnosis and the primary symptoms. So this is done by using standardized and non-standardized evaluation tools and assessment tools. So the primary objective is to actually build a rapport, establish a therapeutic environment, which includes having an initial assessment, where you go through the detailed history, assessing the mental state of the client, um, and more importantly, evaluating the current acute risk that the client poses to himself and to the therapist. So, in mental health settings, the barriers are innumerable. Um, the the ongoing challenge of lack of motivation. Most of mental health clients, they suffer from severe negative symptoms because of the illness, which in turn uh, makes the primary objective of establishing a rapport very difficult. It is very hard to talk to someone who is not interested in having any meaningful engagements with you. So we as occupational therapists are very creative in dealing with these challenges. So then comes the challenge of the environment itself. If you are in an acute mental health ward, sometimes the environment itself is so restrictive, it is not conducive for any meaningful recovery oriented talks. Dealing with aggression and irritable behavior is another barrier. And the distraction level of the client itself. You know, the client, due to the illness, they may be responding to an internal stimuli as part of their auditory hallucination, or a visual hallucination, and sustaining their interest in actually listening to you or trying to live and listen to you. You are trying to help the patient, but they are totally not interested, so they are living in their own world. So it's about having these as the barriers in performing our assessments. It's really important to keep it in mind. So, in spite of all these barriers, we as mental health OTs do explore the occupational function that the person is able to do, and the process is to identify and analyze the functional deficits experienced by the client. Um, so, like I already discussed about the individual care plans. The individual care plan in the occupational therapy report is used to establish the client's current level of function, the focus areas, and the supports needed. So, when you formulate these interventions, they are to assist and decreasing the symptoms while we focus on further developing the overall life skills. So that is the purpose of our assessment. We are formulating our interventions to assist in decreasing the symptoms, while we are further developing the overall life skills. So that broadly covers the ADL, the IADL, the interests, the values, and what is the capacity to engage in any of those activities that we are proposing. Again, this slide talks about the cognitive deficit as being the problem area in attention, memory, planning, all the executive functioning is affected in mental health. So many of our clients have difficulty with attending and maintaining simple tasks, concentrations on simple tasks. Some examples would include the client would be distracted and unable to look at tasks such as cooking or cleaning and shopping or through to completion. Sometimes they may have the functional capacity to do these tasks, but it's about they wouldn't have the cognitive capacity to actually engage in the task. So it becomes doubly challenging for the occupational therapist while dealing with such consumers who have cognitive deficits to work on overall functions of the client and being aware of the cognitive deficits. So it becomes our role to talk to the rest of the treatment planners and the therapy team or the multidisciplinary team to say this person has a cognitive deficit that is stopping this person from actually engaging in this functional activity. So what that provides a catalyst for treatment. So the person may be treated on an antipsychotic, which is a medication that they have, So, but if you have recognized that it is not so much the functional deficit, but it's a cognitive deficit, then when you take it back to the multidisciplinary team and say that this person can actually do this activity, but they are not able to do it because of their hallucination or the frequent distraction due to the auditory hallucinations, then the treating team can actually look at changing the medication for that person. And most of the instances, when they are on the right antipsychotic medications, their response to our therapeutic modules increases. So they may, once they are in a different treatment, and if that treatment is identified as being helpful for the person in dealing with their symptomatology and distress, you can see that that actually correlates to an increase in performance for them. Then our role becomes a lot more easier in channelizing that person's strengths. So I know this may be some fond memories to a lot of people, where we're going to talk about the model of human occupation, the Moho model. But in Australia, it is widely used in mental health settings. Um, so we'll broadly look at some of the important tools of Moho that we use within the Australian perspective. So the Mohost is a very important screening tool that is widely used in different settings in mental health. Then you have the AMS, or the assessment of the motor and process skills, the OCARIS, the occupational circumstance assessment interview and rating scales, the Allen's cognitive level screen, the OSA, which is more a self-assessment, which is an occupational self-assessment, and the DAXA, which is the Domestic and Community Skill Assessment Score. All these, the finding the right balance between promoting independence and autonomy is the purpose of all these tools. We as occupational therapists, offering support can be difficult, particularly when the client is experiencing all these cognitive challenges. But these tools actually help us in screening whether it's a functional deficit or a cognitive deficit, or more so giving an understanding of how much of it is a cognitive deficit and how much of the deficits are a functional deficits. So again, that's a brief description of what these tools mean and how they are useful. From an mental health setting perspective that I've worked in Australia, the MoHost and the DAXA, the screening tool and the DAXA are widely used in most of the settings. So following the assessment and the intervention aspect, it's more about the intervention frameworks. The frameworks within which we are going to formulate our interventions. So this is in assisting in reducing the effects of the disease, disability, and while we are promoting the health and well-being. Looking at goal setting in mental health. So like I already told, ensuring any goal setting is a challenge in mental health settings. Um, but it's all about setting realistic goals. While setting goals in mental health settings, the priority is to make sure that the goals are recovery focused. They help in improving the insight into the current strength and weakness, self acceptance and self esteem, and it gives an opportunity to pursue a productive goal or a challenge for that person. And he's able to when I say he, it's the client that I'm referring to, is able to actually see the goals. um, and all the standard process of having a short-term goal, having an intermediate goal, and having a long-term goal, this is all based on the capacity of the client. So this is a very active slide. where we talks about the intervention framework and the implementation process. So as you can see, the once we do the occupational therapy assessment, that's followed by looking at the areas of occupation self-care, the moho based of where the person sits in, and then the intervention focus areas where we are, what intervention framework are we going to use in, and what therapeutic strategies are we going to use for this person. So this is a cyclic process that we use. And the focus area is normally, like I said, we again focus on our strength. It's going to be based on work, play, and leisure. So following the assessment, the focus areas are identified, and the appropriate intervention strategies and intervention tools and therapeutic strategies are utilized. And these intervention strategies are regularly monitored and with timely reviews. And we conduct frequent OT intervention checks to see if it is still relevant. So ideally, when the client is referred for an occupational therapist, we start with an initial assessment, and then we formulate the intervention, and then we implement the intervention, and at that point we assess the intervention outcomes, and we make any modifications based on that or based on that assessment, and then the client proceeds with the intervention plan. And closer to discharge, or even at discharge, when the client is in the community, the OT normally re-engages to see whether the interventions that has been assessed and formulated been effective for the person in the community. So this happens in three different stages: initial assessment, there's a review, and then there's a final assessment. So we will briefly look at the theoretical framework of MOHO and the model of care provide that MOHO provides us. So so the model of care was first developed by Gary Kilovka, and since then the model itself continues to evolve in further development, with a lot of refinement and revision to its concept. The reason why MOHO is widely adapted in most mental health settings is this strength that it has to change itself and be adaptable and dynamic to the different settings that you put it in. You use MOHO in acute settings, in rehab settings, in community settings. MOHO is very adaptable. It's easy for an occupational therapist to communicate with this language. So that's the importance of MOHO. So my strong recommendation is, this is not enough to just briefly look at MOHO as a whole, but we'll in future slides we will look at MOHO. But anyone interested in mental health and occupational therapy and formulating treatment plans, I strongly advise to focus on MOHO and understand and learn more about MOHO, to see how it actually fits into the systems. So most of you would have seen this. There is this volition. The person has the causation, values, and interest, the habituation, where the roles and routines are looked at, and how the environment plays an influencing aspect, and the performance skills. How the person or the individual is able to process the input, and take it forward. So this slide actually talks in detail about MOHO in action. So in a day-to-day clinical setting, MOHO is utilized to organize and understand how to use occupations into practice. So the predominantly it is to about improve the person's health by understanding how and why meaningful activities are motivated. And some people have this capacity to perform better on those challenges. How MOHO is influenced by volition, habituation, and performance. Uh, MOHO is seen as, sorry, my apologies. MOHO is seen as an open system. Um, and according to this system, the human is a self organizing system uh, who interacts with the environment. And this environment receives through occupation and receives input and output. So there is the individual receives the input, There's output and there's feedback, and environment plays a very crucial role in this. So key to Moho is understanding that all components within it are dynamic. So when any part of it changes, whether it's the skill, the values, or the roles, or the environment, the entire dynamics may shift in either a healthy or an unhealthy way for the individual. Just a brief example would be, say, imagine if you have done an intervention with a client and the client has established a healthy routine, and the client is attending a group in a particular setting, say a cooking group in a community setting. And if there's a cancellation of the group, the way the client is able to adapt to the challenge influences the outcome of our intervention and feedback that we provide to the client. Whether the client goes into a heightened sense of distress and finds that it internalizes that cancellation, or whether the client is able to adapt with the skills that they've gained by using the Moho systems in place, and look at alternatives that they can do on that day to change the routine to engage in some form of meaningful activity. So this is really important, and this is why Moho becomes really relevant in most settings because it's very adaptable. So we again talked about how why there are certain people who are motivated to do what they do. In short words, what are their values, interests, and occupation, and how is occupation behavior organized or structured, and what are an individual's pattern, habits, or routine. How well can a person complete the task or occupation that they're motivated to do? So these are the questions that you'd always put to yourself while you are formulating the intervention plan based on the Moho theoretical frameworks. So from this slide, the key is about the two approaches that we use. So first one is about focusing on the occupations, where we identify the areas of occupational participation, and within each describe how the client's volition, habituation, and skills affect their engagement in the area. The second approach is about focusing on the supporting factors um, around the client's volition. So there can be these are more the external factors that would actually influence the client in engaging in meaningful activities. So as an occupational therapist, it becomes our priority to sit with the client and focus on both the approaches, the internal volition and the capacity to engage in the activities, and exploring those aspects and those strengths, and looking at the external aspects that could influence the person in those meaningful engagements, while we contribute to the while we are formulating the interventions based on more. Okay, so in Moho, the in mental health, uh, Moho approaches are broadly classified into these intervention approach, where you create and promote, you establish and restore, and you maintain, modify, and prevent. So we'll briefly look at these components of Moho. So the first aspect of health promotion in mental health would be the focus on developing a healthy routine. This is always done in collaboration with the client. The client is the one who drives this process, and we assist in developing the same by introducing tools that the client can formulate. The client can assist in formulating the routines. It could be simple things like calendars, having a board with their diary, or things like that, where they can actually formulate how they want to have a routine that's established. Now we're looking at the establishing and restore. Once the routines are identified, then as an occupational therapist, it is important that we focus on assisting the client in establishing the healthy routine that they've identified. This is done by gradually challenging the client, um, and helping them with their work routines and providing confidence in dealing with change. So they can have a clock that works for them, but there'll be changes in that, and it's about dealing with those changes, and being adaptable to that changes. Again, that leads into how do you maintain. So any gain achieved through intervention strategies need to be maintained. And as occupational therapists, we take great care in assisting the client in identifying tools that will assist them in maintaining these functions. What I normally do with my clients once they have gotten identified a routine, established a routine, what I do with maintaining is actually working with the client and the family to see um, devices like a timer or a noise cancellation headphone. Say imagine you have a client who has an illness of schizophrenia and they are trying to engage in an activity like going for a walk, but they find it very distressing with external voices or noises, or if there's a car, or if they're in an area where there's too much of distraction. uh, Having like a noise cancellation headphone is a very easy and simple approach that the client can use to see if they can maintain this recovery. So it's more about they have a healthy routine of going for a walk. You don't want any external factors to affect that. You work with the client to see how best you can modify the environment for the client to assist them in continuing with that activity. Again, this leads into how do you adapt. We are looking at environmental modification and internal modification for the client. The environmental modifications are more what we stress on. It's more about having visual reminders and routine charts, uh, even descriptive items that provide a visual feedback for the client, to ensure that they always feel supported even when you're not there. You set the routine up. These are left in the client in their environment. They control this. It is always there, non-intrusive, but a very friendly, gentle reminder. Prevention, it's very important to ensure that once the client have achieved a level of occupation function, to link them up with activities that they find meaningful, to engage in the community, to ensure that there is an external sense of support for the client. So it's more about identifying community supports like community walks or local activities where you can link in with the client, and they have a work-life of balance that works for them. So the therapeutic strategies that we are going to look for in the following slides. So in Australia, occupational therapists play a vital role in transforming the lives of people who access public mental health service. So as a well delivering range of services, um, we deal in a lot of settings, like we already spoke about, inpatient settings, forensic and community settings. Um, what we do is we work in engaging in activities that are personally relevant, such as vocation and leisure-based activities. Um, it is important that we develop skills and qualities that the person can actually transfer in the environment. So it's more about giving them confidence in dealing with change, personality development, pre-vocational training. All these are therapeutic strategies that we would use. I'm very mindful of time, so I'm just going to rush through a few of these slides. So again, this talks about how we would this slide talks about the changing dynamics that the person would encounter. So this I'm going to explain because again, this is what we do in mental health settings. We break it down. We do the ADL and the IADL checklist. We do the initial recovery planning, intervention planning, which is individual based. So and then our role is very important in ensuring that we promote wellness and recovery plans, and we link up with appropriate community services to assist the client in ongoing recovery. So as an example, in an Australian setting, you would have this would the broad classification of therapy and recovery group. So the therapy groups you would normally classify them as talk therapy or more psychoeducation based, and the recovery groups you would be more focused on recovery through actions. So it's more hands on and engaging in activities while you're engaging in active mindfulness. So things like your cooking groups and things like that would be more the recovery groups. So recovery and mental health, as they say, recovery is a unique journey, not a destination. And any recovery, it has to be meaningful and it's strength based for the person, by the person. So how is it relevant to mental health? So like we discussed, it is unique to the individual, and it's an ongoing process. There'll be a lot of moments of relapse for anyone who is going through a mental health recovery. It is crucial to assist the client in recognizing the possible triggers to a relapse and assist in getting back on the recovery routine as soon as possible. As occupational therapists, we promote a recovery approach to mental health care, and it is ingrained in our national health policy in Australia. So we ensure that the client's recovery, my apologies, the client's recovery is unique. While we formulate the recovery process, we ensure that the uniqueness of the individual um, pay respect to the real choices, attitudes and rights of the person, dignity and respect, partnership and communication, and evaluating the recovery. So, all these aspects are really important where we look at the person as a whole and ensuring that they are respected in all aspects of their care. So, basically, it's in summary, it is about you don't determine what is needed for the client, it is always in collaboration. So, that's the summary of recovery and mental health. So, we as occupational therapists, recovery is a fundamental to our practice. It just overlaps with what we do. It complements what we do. So Tina Champion is an occupational therapist who champions in this space of mental health and recovery. So predominant as health professionals, it is crucial that we ensure all our interactions are recovery focused and strength based. So, and to acknowledge that it is an ongoing process and there will be relapses, and we reinforce the supports for the client and we make them believe that even if it doesn't feel that it is 100%, it is a process. We encourage them with that process. So, dealing with mental health clients, like we said, it poses its own challenges. And it's really important to acquire a set of skills and knowledge that will guide you through while you're dealing with mental health consumers. Like you take any specialty, you will want to focus on some learning criteria. So in mental health, it's more about ensuring that these competencies are always met: safety, which is physical, procedural, and relational, ensuring that you are aware of the cultural issues and being empathetic to treatment delivery, um, legal issues, being objective in your treatment, and ensuring the confidentiality and respect to privacy. It is vital to be aware of the Mental Health Act, which governs your treatment interventions. Um, Capacity building, supervision, and reflective practice, and documentation. These are all the aspects that are predominant to all aspects of our profession, but all the more so in mental health. So this is an important concept in mental health, where as an occupational therapist, you would normally, this is the most important modality that I use. So the therapeutic use of self. So this is where the therapist and care provider incorporates the techniques in a positive and helpful way for the client without hijacking the client's treatment or care. It's more about how you use yourself, and what techniques do you use while you're using yourself. There is an art to this, there is a method to this madness. So it's more about harmonization, where you genuinely engage in active listening. um, Positive regard, this is about ensuring that you always put the client with start the therapy with the assumption that the client is trying the best. It's about having that assumption that whatever they're trying, they're giving the best. Once you have this approach, then you work with in a totally strength based approach with the client. Self disclosure, this is a minefield. You have to be very careful in using this technique. But it's a very powerful technique where you maintain a professional boundary in engaging in self disclosure. But it's about normalizing the therapeutic rapport for the client too. So it's a very important tool. Can be very helpful in establishing a rapport. But always be cautious when using this. um, Balancing the power differential, this is a very challenging aspect of using the therapeutic use of self, because the therapist empowers the client to facilitate change in the client. um, the client automatically sees an hierarchical system where he sees you as someone with authority, and he is the one who has no authority. It is the therapist's responsibility to engage in a dialectical conversation with the client to ensure that you are there to actually help them in their recovery. So that is the importance of therapeutic use of self. So now we're broadly looking at the pathways, the pathways for occupational therapy intervention in mental health. So the occupational therapy therapist and the client, they're both in the same continuum. So it's about ensuring that you communicate with the client in all aspect of the intervention pathway. So since the referral, while you're gathering the information, while you're engaging in the initial assessment, while you are exploring the reasons for the interventions with the client, goal setting, while you're planning the intervention, and when the client is actually performing the task, while you're assessing the client performing the task, when you're documenting the outcome, you've documented the interventions, and you're preparing the discharge summary. Your interaction with the client is constant. It is unlike others, a few settings where once you've done the assessment, you go in and you prepare your report. In mental health, it's constant. This process is constant, and the review aspect of this is very important too. So we'll quickly look at the few of the emerging trends. I have prepared these based on the occupational therapy emerging trends in Australia. So in Australia, in mental health, OTs are playing a very crucial aspect of care in the acute psychiatric settings, in the community settings, and the forensic justice health, mental health settings, which are all very recent areas of work. So we'll quickly look at the forensic settings. So in forensic settings, the occupational therapist provides the link of engaging in occupation that is vital for human, as is essential for health and well-being, while in a restrictive environment. The setting itself can be very restrictive. It could be a secure mental health facility, or you could be dealing in a forensic or correctional facility like a jail, where you won't have many tools that you'd have. But your challenge is to reduce the recidivism or the reoffending behavior of the client. To do that, you need to understand and create an environment where you foster a sense of recovery within the client. How you do that is we use a lot of creativity to work with the rest of the team to formulate activities that are both safe in the setting and are meaningful for the client. Um, some considerations like engaging in a cooking group in a controlled kitchen is an example for someone who may not have other opportunities to engage in, or even using a sensory room. As occupational therapists, we can promote mindfulness, um, engaging in sports, gym, bodybuilding, all these activities in a controlled environment. We can do all this while we work in a restrictive setting, provided we have the client on board. I've got a brief summary where we look at, and this will give you a broader understanding. So, in a forensic setting, this is something which we normally deal with. You have an aggressive client in a who's mostly in seclusion due to threats of violence to staff, and as an occupational therapy, the referral comes to you, and you start with the multidisciplinary team, and you take up the referral, and then you meet the client, you establish a rapport with the client. Unlike in normal settings, you would be in a physical barrier where you'll have a physical barrier in front of you and the client. In your first interaction, it's going to be very challenging. The client is already aggressive, he's not interested, but then you go in and you say, hey, I'm the OT here, and you're talking through a glass, and the person is listening to you, and you offer what you have. And then you how do you do this? You offer the person an interest checklist. You say, look, I know that you are not very interested, kindly go through this is an interest checklist. The person goes through the interest checklist and then finds it, okay, so I can engage in these things. Okay, and then the person comes back and you review the interest checklist, and you said that the client is interested in sports and music. So then it becomes your responsibility to advocate for the client in the multidisciplinary team meeting, to say, hey, this person is bored, he's not engaging in any meaningful activity, and that is probably causing a lot of the aggressive behavior and his maladaptive behavior traits. How are we going to get this person to get focused? Then we reflect on his strengths and work on these activities, and we provide opportunities for the client to engage in a safe environment where his safety, the client safety, and the therapist safety, and the rest of the staff safety is maintained. But we engage in a sport activity. I've done this a lot of times, and once the person engages in that activity, he gets a sense of trust with you, and then based on that, you can improve on that trust and work in completing a proper functional needs assessment to facilitate the discharge with the client, to see what needs to be done in the community. In acute mental health settings, this is relatively new, where the occupational therapists have a very crucial role in playing, because in acute mental health settings, it is difficult to engage these clients in the acute phase of illness. They have difficulty in building rapport, or they are at increased risk of self-harm and suicide. So occupational therapists play a vital role in providing a non-threatening environment, an opportunity for the client to engage in activities that can reduce distress. Uh, just activities like listening to music, art, or having access to a sensory room can actually provide a non-stimulating environment, which can A, reduce the distress, and B, increase the ability to have some meaningful conversation. So the occupational therapist designs, implements, and provides ongoing review and evaluation of individual and group programs in acute based settings. So our role is predominantly recognized in managing de-escalation strategies by using sensory integration. Sensory integration in itself in acute mental health settings and rehab mental health settings is a topic of its own. So there's so much of work that is being happening right now, especially in Australia. In the time that comes through, will have more discussion on those if there's an opportunity. So occupational therapy in community settings, this is really challenging because as occupational therapists in community settings, we are working with the client in their environment, in their house or in their community settings. Our goal is to actually formulate a plan that would incorporate using the activities that the client do to maintain their recovery in the community. Relapse prevention plan, preventing the hospitalization, the trauma associated with the inpatient care, the burden to the taxpayers. All these are criterions that we will have to consider while we are working in the community. Our main role and supports come from the community. So we explore and network with the community to find appropriate community supports to link up with the person, to form a safety net for them to exist in the community, enjoying what they do in a meaningful way. So that's again, that explains what I just spoke at. So in conclusion, we as occupational therapists have a critical role to play in interprofessional mental health care team in Australia. So, and we are well positioned to lead the development and enhancement of services that promote mental health and well-being through active engagement and participation in meaningful activities and life roles. That is it from my end.
Thank you very much, Dr. Sabarish. Are there any questions anyone wanted to ask? Dr. Sabarish, can you please stop the slide sharing so that we can see you and other people can see you, and everyone else, please feel free to turn on your videos so that you can see each other. Thank you. Anyone wanted to ask any question, or if so, I'm understanding that you can always give a follow-up question. You can write to Dr. Sabarish. I'm sure he would not mind replying your queries if you have. Is Dr. Bijlani here online? I just wanted to confirm.
I'm unable to see her here.
Yeah,
I have a question.
Go ahead.
I don't work in mental health field, and I'm just curious, like, I'm not sure if there is too much occupational therapy being practiced in our area. I'm in United States of America, and if there is, I'm really unaware of it. But in case there isn't any, and if somebody wanted to start that in the mental health setting, what is like, did you go through the process of actually like starting from ground up, or did you walk into an established occupational therapy practice in mental health?
You're muted, Dr. Sabarish. Can you please turn your speaker on?
Thank you. Thanks, Harsh. Thanks for the question. I have had the opportunity of actually working in both an established setting, but my initial work in occupational therapy in mental health started in Australia, where I was an occupational therapist in an inpatient rehab setting, which which was recommencing after 35 years of inactivity. So that was when in 2007, when recovery was huge in Australia, and the recovery model was widely adapted. So I'm more than happy to give you some guidance on that. I'm happy to email you if you just email with any specific questions with regards to training, assessments, and setting up of settings. But the challenge in setting a new occupational therapy service in an inpatient mental health setting, it involves a lot of other spheres So it is always a multidisciplinary team approach. So there's a psychiatrist, social work team, a psychologist, and rehab specialist, and seeing if a role of an OT in service delivery is appropriate to that settings.
Yet another follow-up question is, there are two other aspects, I was involved in. One was, briefly involved in the drug abuse area, and then that was one, and then of course dementia, because I deal with seniors. So if you want to just emphasize on those two areas, that will be great.
Absolutely, absolutely. In drug and alcohol rehabilitation, I mean, most of the role that occupational therapists in Australia do in drug and alcohol relation rehabilitation is more a recovery focused approach too. There is a harm minimization approach that we do in Australia. So where we acknowledge that drug and alcohol and substance misuse can be seen as a modality of self-medication for a lot of the people dealing with it. And the risk associated with substance use is acknowledged. So the recovery frameworks guides us in ensuring, as occupational therapist dealing with drug and alcohol, the focus is about ensuring community supports. So we have special clinics where they can come and safely engage in the practices. So whether we have a needle program in the community where mental health consumers come in, and we at that opportunity use about engaging in motivational interviewing. That is the key that we do to see whether they are ready to change. And occupational therapists have an important role by providing them with additional supports in the form of vocational rehabilitation, sensory rehabilitation, meaningful opportunities such as sports groups, play areas, things that they can do to distract themselves while they are engaged in a harm minimization approach. That is in the sphere of drug and alcohol. With regards to geriatric, there is a whole spectrum of new services that are happening where occupational therapists, right from inpatient geriatric care to community geriatric settings, right from false assessments, dementia care, use of sensory spaces, augmented reality, AI. The scope is endless, and although I have not had direct experience working in geriatric settings, we have networks with colleagues improving the quality of life within an inpatient or a community setting.
Sabarish, there was a couple of questions in the chat box. So if you want to click the chat and then.
Okay. Therapeutic strategies that you have used. That's the first question from Hasti. The example that I gave, where we deal with in a forensic setting, where we deal with an aggressive client, um, that example, the therapeutic strategy that we have used in that setting is about therapeutic use of self and using the MOHO framework of using modalities such as interest checklist and activity assessments. So first is the therapeutic strategy used was the therapeutic use of self, where we acknowledge that the person, due to their behavior strategies, have formed behaviors that are maladaptive in nature. So they are unable to have a meaningful conversation even when they need the help. So they're not able to recognize that they need the help. So you reflect to the person saying that, okay, I'm here if you need me. These are the things that I can do. Conversation. The one of the most common strategies that I use is therapeutic use of self and DBT principles. So dialectical behavioral therapy is fundamental to having a meaningful conversations that I use. Hope that answers your question. The second question is, what is a role in return to occupation for a student? Do there is a role in disability in mental health for client? Suhas, do there is a role in disability for mental? So two questions. First, the role of return to occupation for student. Return to occupation in student, any return to occupation has two components. One is assessing the current capacity and the pre-vocational interest for the person. So there is, you can split it this way. So you have a pre-morbid functioning of the person. So before the person is mentally unwell, what were they doing? What was the capacity that they could engage in? So you do that by analyzing and sitting with the person and doing a complete history check. And then you look at their strengths. Okay, say this person was working as a checkout staff in a supermarket, and now they have had schizophrenia. They are unable to work because of their auditory hallucinations. When they are in a supermarket environment, it is already heightened stimulation. It's a process where they can't work, go back to work. They're started on medications. Antipsychotics have helped them. They come to you and they say, as an OT, I need to go back to work. What were you doing before? Working in checkout. Okay, as an OT, you do an analysis for them. You do an activity analysis. What is your work involved in? Okay, so how are you going to plan your intervention? You talk to the person, talk to the family, talk to the work. You look at the environment, you do a site visit for the person. You see this person can't be working in a checkout while he is still recovering. How about this person works in a back office doing some data entry on the computer? How about we have some staff education so that when this person is not traveling well, he has an option to go home? These are the strategies that you can work out with the person to see how they can be rehabilitated back in work. It is more about making it meaningful for the person. This is just one example that I just gave off the fly. um, Role in disability in mental health for the client. There's a role in disability in... Suhas, I am not able to understand that question. Mental health itself is a disability which affects a lot of the functional capacity for the client. So don't we see that as a holistic aspect of care. Mental health will be debilitating for the person in informing, in doing everything. Self-care is affected. The therapeutic relationship are affected. So you need to focus on all those aspects. Hope that answers.
Yeah, those were the chat questions. Is there any other questions? I've FYI, I have posted the webinar feedback and certificate link. You need to complete the Google form to get your certificate via email. So all attendees, please do so within 24 hours. I see someone typing, so let's give a second and then move forward to the vote of thanks. Typing. Someone is typing. So, but anyway, Harsh, would you like to get started with the vote of thanks? As we get the question, we can still go back and answer the question.
Yes. Yeah. Thanks, Karthik. Thank you, Dr. Sabarish. What an informative and amazing presentation it was. And while you were presenting, it took me back in my student days around mental health, and in those days, I'm sure some of you might be able to reconnect with that or relate to that. Is when we used to study these conditions and we used to know about, so what is the role of OT in mental health, and we used to think that I wish I could talk to someone who works in mental health and who can actually tell what happens on the ground and how do you actually work with clients. And that is what you have done tonight, Dr. Sabarish. So thank you very much for that. Um, it is mental health is the role of OT is it has got a significant role. And as I remember once we were advocating saying It is not just about talking therapy in mental health. You need doing therapy, and occupational therapists provide that doing lens, which is very important. And all the policymakers and decision makers, they're looking for people who can actually go out and bring some change. And how you were highlighting the strength-based approach. You also talked about the barriers, aggression, and how irritability of the patients and how you deal with that, and things like knowing the Mental Health Act. And this is something, you have to be. It just shows how much skills, how much courage, and how much agility you need to work in that space. Um, and I have come across some Indian OTs who came abroad. I have been in touch with some in New Zealand, and when they start a job in mental health, they there are certain challenges. It takes a while for them to get their head around it, how it works. And what you were presenting tonight, it shows that you have got a really good grip on mental health, and also mental health in the Australian context. It's not that easy job. um, I because it's not a straightforward pediatric therapy. I have been a pediatric therapist. It's not that you can, but mental health it has got some additional layers of challenges, and I'm really proud to listen to you tonight to see how well you have established yourself in a foreign country, uh, with a range of I mean, Australia is a huge country, and mental health is on the top of the government's agenda there. And it's great to hear from you direct from the source. And I'm sure all the participants today, they they would have benefited from that. And once again, I want to thank you, Dr. Sabarish. I want to thank everyone for attending tonight, because International Chapter, that is what we are trying to do. We are trying to give back to our profession. We are trying to give back to our country, and we will keep doing these seminars time to time. Um, Dr. Suple, who is our convener, he is away today, so I want to thank you from on his behalf as well. Dr. Bijlani and Dr. Sivastava, the president of IOTA, they have sent their apologies. Otherwise, they would have been here. And that means that I'm doing the talking. Otherwise, they would have done that. So no, thank you very much. And let's keep doing this. And yeah, Dr. Sabris, you wanted to say something before we wind down?
Thank you. Thanks for the acknowledgements, Dr. Harshvardhan, and thanks for all the participants, and thanks for the organizers for the opportunity. It's a pleasure to talk about the field that you work in. And this is just a tip of the iceberg with regards to mental health and OT's role. There is a lot of scope of practice. There's a lot of new innovative ideas that are coming through, and scope and areas. Hopefully, based on the interest, we will look at furthermore education on this sphere.
Thank you very much.